Kalyanasundaram, his first lecture on CTO PCI, common difficult scenarios and how I troubleshoot. Dr. Arun Sundaram, please come up and share your slides. Yes.
I hope you guys can see the slides. Good morning, everyone. Thank you so much. It's truly an honor and a privilege to be part of the Bangladesh Intervention 2021. And would like to thank both BSCI and Sky for having included me in this. So I'm going to try and stick to the time. We're at 10:35, yes. So can you guys see the slides?
Yes,
we can.
All right, lovely. So, all right. CTO PCI, as we know, you can run into a lot of problems, and we're going to try and kind of go over some solutions. I'm going to do this in a case-based approach. So obviously, tons of things can go wrong in a CTO, or rather, I should say, we're not talking about complications. Just even doing the CTO per se, you could run into one roadblock or another. You can't penetrate the cap, you've crossed the collateral, can't cross the collateral, microcatheter won't go, you're trying to do ADR, and you just can't do it. So problems abound. So we'll kind of look at a couple of solutions, and then this was pretty much now published. So I would like to kind of show how this would have practical application in a real world situation. So again, typically, just the nuts and bolts, when you have wire across the cap, but the gear won't follow when we're talking about antegrade here. I mean, the first cardinal rule is backup. I mean, if you look at it many times, people go into poor backup, and then you kind of struggle all through during the case. Of course, and then you have the entire, try the lowest profile balloon, different microcatheter. You can do Grenadoplasty, and for those centers that do have laser, it's something to consider to do it on. Contrast, it's a bit more aggressive, but possible. You could go, if you can't go through the cap, if the device won't go through the cap, you can go around it, can do an external cap crush. All else fails, go to all rota, but of course it does mean losing wire position. And if that doesn't work, switch strategies and go retrograde. Now, again, there are times when you can't even get across the cap, the wire. So again, you can circumvent the point of obstruction using techniques like scratch and go or base. You could try to just create dissections using Carlino. If you do have laser, great. If not, again, go retrograde. You kind of see the common theme. You're trying to increase backup, penetrate, use a little bit more aggressive device, or bypass it. Likewise, if you don't know where to go, the easier thing is to go retrograde or use IVUS and get into that particular area. And same strategies, again, apply when you go retrograde. You might either want to try knuckle or Carlino. If that fails, go switch direction and go cart, or you could do a retrograde base. And if nothing works, you need to know to stop the case, get a CT, help yourself so that your next attempt is going to be better. Again, there are times when you just can't externalize it and get in. I mean, you might want to switch to a different wire or do tip in. Now, of course, before we had the the RG3s and the R350, the traditional, the Viper wire, we always used to use the Rotoglide. I mean, there are still cases where you might have to do it, although it's increasingly become infrequent. Then the others, many times, having a stent already in place can be a boon. It can also be a bane. So depending on how your instant CTO is, you might want to adjust your strategies accordingly. Again, in the interest of time, I'm not going to go into each of these in depth, but I do want you guys to be aware that this actually the algorithm with an algorithm paper is already published at this point. Now, sometimes when you do have an unexpanded stent, I mean, you have to do something different. Even when you get your wire across, you still want to, change the underlying protoplasm. So you want to, if it is because of underexpansion and you're true, you want to definitely open it. I mean, now we have open balloon in our parts of the world. I mean, of course, you can use IVL, laser when it's available. So you want to create something to get to the tissue outside the underexpanded stent. Now, there are times when you've had to go around it and crush it. Again, basics always start with, especially in a septal when you have a wire across, but microcatheter won't, is increased guide support, use a guide extension, whatever. You might want to consider dilating the septal if you are for sure if you do know that it's a complete, the track where you're dilating it is septal. Different microcatheter, sometimes using a shorter microcatheter works. Sometimes, again, we don't use this so much anymore, but you might want to use a wire with a slightly different body. That doesn't work. You might essentially want to give up on the collateral and go to a different collateral, or use a retrograde wire as a marker and come antegrade. Now, with epicardial, the only thing that I'm going to tell you is that you do not dilate it, and you got to be much more respectful. Here again, when you do have, you're in the CTO body and it keeps going to side branch, this is often a problem even with knuckles. You might want to use a wire that forms a bigger knuckle, typically about a 200. I mean, sometimes there are wires that form much bigger knuckles, and that's what you need to do, such as your Gaia or your Confianza Pro 12, etc. And again, remember, the common theme is you're trying more aggressive maneuvers. If that doesn't work, switch strategies. You might want to go retrograde at that point using your antegrade gear as a marker. And if that doesn't work, stop and do, take a CT. So I'm not going to get into the difficult ADR and RER just in the interest of time. And I'm going to try and basically get to the case, because I think we kind of used up the initial 5 minutes with the introductions. So how do you actually apply this? I mean, again, like I said, the algorithm is published. It's out there for people to look at. So in a real world scenario, so here's a patient who had an appropriate indication for a CTO PCI of the LAD, and this was already a second attempt or a third, I don't remember. In fact, when I first looked at the angiogram, I thought, all right, this shouldn't be too challenging. But anyways, be it as may be, those are famous last words. It was the LAD that was the target. Here was, so as you can see, the proximal cap was pretty visible. Distal cap was at a bifurcation, which I would like to preserve, and it was a pretty short CTO segment. So my initial, again, the first thing, once you have analyzed the angiogram, is to have a strategy. You kind of want to know, all right, this is what I'm going to do. There's nothing from the right at all, really, in terms of collaterals, as you can see. So the plan was to do antegrade wire escalation. If that fails, I was probably going to do go retrograde, and if that fails, to probably do an high in ADR and try and preserve the bifurcation. So here is where we started. So again, not a big fan of using single guide, especially when I have the option of going retrograde and it's an IPSI collateral. I try to do it with a ping pong guide because it just makes life a lot easier. So basically, as you guys can see here, I have two guides in the left main. I'm going to kind of go back and forth. You got to be careful about this. That's the collateral. Again, it's not something that you want to take unless you really have to. And the initial plan was to go antegrade. Your LAO caudal view just kind of shows you that there is a lot of calcium. Again, this particular patient did get a CT outside, which we tend to do if it's a redo, etc. But unfortunately, the CT was done at a center where they kind of botched it up, and the patient wasn't willing to get another one, so I had to not really use it much. Now came problem number one. I can't penetrate it. So tried the usual maneuvers, guide extension catheter, etc. Took the stiffest wire that was on the shelf. I really couldn't do it. This was in the pre-laser era, before laser was launched in India. Of course, you could circumvent the thing as discussed and use base or switch retrograde. I kind of decided to go retrograde. So the retrograde option itself wasn't too much of a challenge. Got a wire pretty quick across. Got my microcatheter across. So again, kind of thought, all right, now really close, short segment, should be able to wire this retrograde. I did try retrograde wire escalation briefly, didn't work. So quickly, again, switch strategies. Now, this is where the problem solving piece comes about. So if something's not working, don't get dogmatic. Yes, it's a short lesion. Yes, I should be able to wire it, but if it didn't work, it didn't work. And so quickly moved on to guide extension reverse cart. And for those that are unfamiliar, essentially what you're trying to do is you're using a guide extension catheter to make reverse cart easier. So it gives a better target, and you don't have to traverse this long risky area, which here would include the left main. So by using a guide extension reverse cart. So you balloon antegrade, and then the same space is connected by your retrograde wire. And once this is done, your retrograde microcatheter enters the guide extension catheter, and the rest is easy. Now, next problem, retrograde microcatheter wouldn't move. So, all right, so wasn't the end of the world. So I just did a quick spin, and I'm like, all right, now I got my antegrade microcatheter over the retrograde wire, and I can just bring it forward. And here, again, with the calcium, the Carol wasn't handling great, so it kind of switched to a fine cross retrograde just in the event that there'd be a problem. Couldn't move retrograde, couldn't move antegrade. So now I got a problem. And again, going back to the algorithm, I could try Carlino or Rota, which would mean I would have to lose wire position. And again, a lot of the other options, I'm already thinking about a lot of this. This obviously doesn't hold true at this point. If I pulled it out, put a new low profile wire, there's no way I can get an RX1 into a retrograde externalized wire. So some of these things just didn't apply. So my plan was at this point to go to an external cap crush. So I'll actually show you another picture of that. So what I did do here was we've already gone retrograde. So this is all done, right? So we also found out that in the hospital, the Rota console at that point, again, didn't work. They told me initially that, it's a big center and they had it, but for some reason, there was a technical glitch. So this is external cap crush, where you are kind of going outside that particular area. And this is from another case. But the crux of it is you go subintimal intentionally, leaving the Y there, and take a balloon, dilate it, you're kind of changing the architecture, and then you're able to traverse the whole spot, right? So here, as you can see, what happens is left the retrograde stuff here, got a knuckle going into the subintimal space, and then used a ballooned across the retrograde microcatheter. I thought, okay, maybe this will free up the retrograde microcatheter. Still didn't work, but now I'm already set up for ADR, and I used my retrograde wire as a marker, and I was able to do that without too much of difficulty. So I just got my Stingray balloon down. I think most of us are pretty familiar with ADR at this point, so I won't bore you. Obviously, the view on the right is correct. The view on the left is wrong. I just did a stick and drive. And the rest turned out to be fairly cookie cutter. So once this was done, again, secure your LAD, which is what was done here. And again, use imaging to understand where you are, understand why we're having so much trouble. It's just a lot of calcium. This was post stenting, had to use an opiate balloon, but that was the final result. So in general, CTOs can be challenging. There can be a lot of problems. Know your techniques, have a strategy, and good luck. Thank you. So I guess a couple of minutes for discussion.
Dr. Abu Muhammad, you're on mute.
Yeah, thank you. Thank you, Dr. Arun, for your outstanding and brilliant presentation, and as well as the sharing of your case with us. So any question from our panelists and from attendee fellows as well for the speaker?
From the chairperson first, probably.
So, Dr. Arun, just one thing from one question from me. How is the experience regarding the complication of you experienced complication, especially during antegrade procedure or retrograde procedure, and how is the complication rate?
So, in fact, one of my favorite talks is avoiding complications. I think one of the biggest reasons we draw a lot of bad press is just because of complications. I think the key with CTO operators and in general, wherever you are on the learning curve, or even if you're a quote unquote expert, is knowing when to stop. Many times, and even in the algorithm, if you see it, it's like they typically, you're running into problem, solution, and if something isn't working, you got to have to bail out and then essentially, plan something for a later, for a later date. And that's okay. It's okay to walk away and not have a complication if you can avoid it. I think that's a very, very critical part, as we all go on this journeys to know, when you're dealing with CTOs. So I would typically say the complication rate is, it's about 1% or less. Now, that being said, You could have a perf. I mean, perfs are the one thing that always comes to our mind when we're talking about CTOs. So even as you're pursuing each strategy, I think you need to do a continuous risk-benefit analysis. Think about, hey, how badly do I want to do it? What are the potential things that could go wrong? And what happens if something does go wrong? Like, is your echo guy around? Do you have a covered stent? Do you have a pericardiocentesis kit? Or, I mean, those things should be going on in the back of your mind as you're doing all of these things. So typically I would say it's less than 1%, but do be prepared for complications because they could occur eventually.
Yeah.
Thank you. Thank you, Dr. Arun. I am Professor Mir Jamal, Secretary General, Bangladesh Society of Cardiovascular Intervention. For our
Hi,
young
sir.
colleagues,
Dr. Shafik.
for
Yes,
young
sir.
colleagues, Professor
Dr. Shafik.
Professor A.K. Rahman, I am
Yes, sir.
talking with him. For our young colleague, would you please tell regarding the escalation of the wire for antegrade proceeding with antegrades for our younger colleagues?
So again, wiring is there are subtleties, and again, a lot of experts on here, and each and everyone I'm sure has their own preference. But in general, the way I approach it is, if I am truly probing for a microchannel, it's something in the XTR or XTA. I mean, obviously the penetration forces are a little bit different, 0.6 versus 1. So it would be one of those two wires. If I'm looking for a little bit more penetration, or if I'm not sure about the course itself, I tend to start off with a hydrophilic polymer jacketed intermediate wire, such as a Pilot 200, or you could go with a Mongo. If I really want penetration, it's the Conquest Pro 12 or your Conquest Pro. Sometimes I do need a lot of directionality, and if I'm really looking for those kind of things, I start off with a guy a second or a third. But in general, most of your wires should fall in one of these 4 categories. Now we do have newer players in the market, so try to minimize your Me Too products. Get very familiar with wires in these categories, whatever you pick, and then use a lot of those.
Thank you very much. Actually, we are short of time, in fact, because we have spent 20 minutes now.
Hello.
Yeah. Yes, sir.
Dr. Shafik.
Yes, sir.
I want to talk with Dr. Umar. I have a query.
Dr. Arun.
I have a query. If a patient having CTO in left anterior descending artery, but patient remain asymptomatic, one subset, or if a patient having significant, that is not significant lesion in the LED by FFR, then how can we manage such a type of patient? LED is a very main vessel of the heart. So how can we manage it?
In the interest of, I mean, again, you guys are experienced clinical cardiologists. If you do think there's a large area of ischemia and there's going to be a potential prognostic benefit, then I would say yes. I mean,
Yes.
you have 2 options. You want to revascularize either with a minimally invasive cap bypass surgery, which is not a bad thing if you have a good target, especially if it's a very large area, or you could do a CTO PCI. Now, I'm sure there are people even on this panel that might say, well, the guy is completely asymptomatic now. So why don't we do a really aggressive trial of medical therapy? If there's no ischemia at all, which I'm not sure would be the case, then perhaps you could continue to manage them medically. You could just ping me. We can talk about this offline in the interest of time, if that's all right, sir.
Dr. Arun, another simple question. Just how often did you take the help from the CT angiogram?
So typically, anytime there is another expert has tried, failed, or there's a post bypass patient where I don't know the graft location, for whatever reason, there's really bad anatomic ambiguity, then I do it. I don't do them routinely, although I do think it helps plan it. But again, India, Bangladesh, we need to be cognizant about cost. You need to do it at a good center, otherwise it's a waste of money and effort. So yeah, I mean, I pick and choose the cases where I do CTs.
Okay.